along the universe. I am honored to welcome all you with us today to start our workshop at the pre-congress of the first international conference of the Faculty of Sports, Alexandria University, and I am honored to introduce Professor Mohammed Bilal, the Dean of the Faculty and the President of the conference. Please, Professor Mohammed, unmute yourself and the mic is yours.
Thank you, Dr. Ayman. On behalf of the Faculty of Sports Education, Abu Qir, Alexandria University, I would like to thank Egyptian Venous Forum and International Union of Angiology for their sponsorship of this workshop under the title of Champions Rehabilitation After the COVID-19 Infections and Anticoagulation Therapy. I also welcome all the speakers and participants. This workshop will be held before the opening of the college virtual conference, which will start tomorrow under the title of Sports and Health, National Security. In partnership with the Ministry of Youth and Sports, the University of Constantine in Algeria, and the British Academy of Sports Science and Technology. The conference will be held to realize the vision of the Egyptian state and President Abdel Fattah al-Sisi in sports and health, and invite all of you to continue participating in the conference to enrich the scientific aspect and come up with recommendations that achieve the ambitious goals of the conference to reach the quality of life. Finally, I would like to thank the Department of Biological Science and Sports Health at the Faculty of Sports Education, headed by Dr. Ahmed Omran, Conference Coordinator, on the implementation of the conference. Now, we'll leave the talk to Dr. Asad Kiki and Dr. Ayman Fakhri to begin the workshop. Thank you for your honor to participate.
Dr. Ayman.
Please, Dr. Asad, the mic is yours.
في البداية تفضل دكتور أيمن.
I want to introduce Professor Asad Kiki. Professor Asad Kiki is a professor of basketball training, and he's the vice dean of the Faculty of Sport Education. He's the president of the workshop today, and he is specialized in basketball training, and he got the highest license for training of basketball in Egypt. Professor Asad, the mic is yours.
شكرا دكتور أيمن. بسم الله الرحمن الرحيم. يشرفني التواجد مع حضراتكم بورشة العمل. طبعا مش هزود الكلام اللي قاله الأستاذ الدكتور عميد الكلية على عنوان الورك شوب بتاعنا اللي هو محاذير التدريب الرياضي في الألعاب الاحتكاكية بعد العلاج من كورونا واستخدام مسيلات الدم. طبعا بهذا الصدد أتوجه بالشكر للأستاذ الدكتور محمد أيمن فخري مقرر الورشة، الأستاذ الدكتور أو أستاذ جراحة الأوعية الدموية ورئيس الجمعية المصرية لعلوم الأوردة والسكرتير عام الجمعية المصرية للأوعية الدموية، فيما بذلوا من جهد لوصول هذه الورشة للمستوى العالمي بتواجد النخبة اللي موجودين من أساتذة علماء متخصصين في جراحة الأوعية من داخل مصر وخارجها، وهترك لحضرتك طبعا تعريف كامل بسيادتهم. بالإضافة إلى مجموعة كبيرة جدا أنا أحب أن أنا أرحب بيهم من داخل مصر، عشان كده بتكلم باللغة العربية. الأستاذ الدكتور سعيد الملاح، أستاذ جراحة الأوعية الدموية ورئيس الجمعية المصرية لجراحة الأوعية الدموية. أستاذ دكتور إيهاب نبيل، عميد معهد السكر ومساعد محافظ المنطقة الروترية. أستاذ دكتور مجدي أبو فريخة، أستاذ التربية بكلية التربية الرياضية جامعة طنطا ورئيس الاتحاد المصري لكرة السلة. أستاذ دكتور أيمن فرغلي أستاذ الأمراض الصدرية ورئيس اتحاد الكاراتيه سابقا. الأستاذ أسامة الأحمر محافظ المنطقة الرتبية. أستاذ دكتور عماد فتحي أستاذ الأمراض النفسية ورئيس منطقة الإسكندرية لألعاب القوى سابقا، وطبعا صاحب الرقم القياسي المصري في ال 100 متر. أستاذ دكتور عبد الباسط صديق أستاذ الإصابات الرياضية والتأهيل البدني بقسم العلوم الحيوية والصحية بكلية التربية الرياضية جامعة الإسكندرية. في البداية الورشة دي ورشة مهمة جدا للمجال الرياضي، وتناقش موضوع هام جدا وتطرح مجموعة تساؤلات عدة تشغل تفكير الكثير من العاملين في المجال التدريب الرياضي لتخص اللاعبين اللي تم إصابتهم بالفعل بفيروس كورونا. أحب أطرح التساؤلات، يمكن يكون دي أساس المحور اللي احنا إن شاء الله نطلع بيها لفعاليات هذه الورشة. هل كل رياضي أصيب بفيروس كورونا يجب أن يتلقى العلاج بمسيلات الدم؟ متى يبدأ ومتى ينتهي العلاج به؟ هل من الممكن أن يمارس اللاعب الرياضة وخاصة الرياضة الاحتكاكية أثناء العلاج؟ ما هو التوقيت المناسب لبدء ممارسة النشاط الرياضي بعد الإصابة؟ كل دي تساؤلات يمكن خلال الفترة السابقة بمعرفة الناس أن في ورك شوب مهمة جدا في هذا المجال طرحت هذه الأسئلة، فأنا حبيت بس أن أنا أطرحها. وفي نهاية كلمتي طبعا هترك الكلمة للأستاذ الدكتور محمد أيمن فخري، موجها في النهاية كلمة شكر للجهد المبذول للأستاذ الدكتور أحمد عمران رئيس قسم العلوم الحيوية والصحية كلية التربية الرياضية جامعة اسكندرية لتنظيم هذا أعتبر العرس العلمي الجميل. شكرا لحضراتكم، والميكروفون مع حضرتك دكتور أيمن.
Thank you, Professor Hassan. Thank you. It was really a great honor for me to start our scientific meeting now under the aspects of the International Union of Angiology and the Vascular Society of Egypt. It was a great pleasure to start our work today by welcome speech from Professor Said Al-Mallah, Professor of Vascular Surgery, Monfaya University, and the President of Vascular Society of Egypt. Professor Said, please unmute yourself.
Thank you, Professor Ayman. It is my great honor to be with you in this meeting. And on behalf of the Vascular Society of Egypt, I welcome you all, Dr. Ashraf Sobhi, Minister of Sports and Youth, Professor Abdelaziz Qonsowa, President of Alexandria University, Professor Muhammad Abdelhamid Bilal, Dean of Faculty of Sports, Alexandria University. Eminent speakers, panelists, chairman, moderator, and the attendee. The Vascular Society of Egypt is a non-profit organization and community-oriented. So the subject of this meeting, which is champion rehabilitation after COVID-19 and coagulation therapy, is an enigma causing a lot of debate. I hope by the end of this meeting, we can solve the problem or a part of it, because all we know that the use of anticoagulation in the patients of COVID-19, it can extend to 3 months and maybe more. The champions are exposed to many types of trauma during playing. So I see that this gathering can solve this debate. I wish all the success for this meeting, And thank you very much. شكرا دكتور أيمن.
Thank you, Professor Said. It was a real pleasure to have these very nice words to start our conference today. And now it's my great honor to thank Mina Farm, the companies sponsoring this workshop. I'll start introducing Professor Eduardo Ramachati. Professor Eduardo Ramachati, he is a very big name, and he's a professor of the front runner, dealing with a lot of COVID cases in Brazil, in São Paulo University, and he is running more than 40 trials now, dealing with thrombosis. He is a leader, of one of the greatest leader in the world, talking about venous thrombosis, and we're expecting a lot for the next few years, telling us a lot of his trials, some released, and still there are a lot to be released very soon. Professor Eduardo, it's an honor to have you today with us, and the mic is yours.
Thank you, Dr. Ayman. And I need you to allow me to share my presentation. So host has disabled me. If you could allow me to share the presentation, that would be good. On Zoom.
Yes. I think you can start sharing screen now.
No, the Zoom is not allowing me. You guys need to make me host. Otherwise, it's not possible to share the presentation.
Yeah, just a second.
Okay, good. No worries. And it's a pleasure to be among good friends. You have asked me to talk about timing of anticoagulation, and I'll do it in around 15 minutes or even less, and then we will discuss very fast what we're doing here with COVID. Okay, good.
Now we are the host, sir.
Yep, and I think you guys are now seeing my presentation.
Yes.
Okay, so you have honored me with the possibility of presenting for how long should we treat thrombosis, and I'll do it in around 15 minutes, and then we'll move a little bit for COVID treatment. I have a fair number of disclosures. I worked with the development of all anticoagulants. So when we're treating DVT, and it's a very common disease everywhere, particularly now in the COVID area, we have 5 objectives. Number 1, preventing the death by pulmonary embolism. Number 2, preventing recurrences. And that's why I'm talking about timing of treatment. When we treat the acute phases, we prevent pulmonary embolism death, and then we moderate and we modulate the timing of treatment, we are preventing recurrences. We don't want the patient to have post-thrombotic syndrome, and in some cases we perform the thrombus removal. We want to limit the swelling, and finally, we want to prevent bleeding. That's why we need to pick the correct dose, the correct regimen, and the correct anticoagulant. So when we're talking about timing of treatment, we're talking about decreasing VT recurrences. And how do we do that? We can treat patients with heparin plus vitamin K. We can treat patients now with 4 different oral direct anticoagulants, and each one of them has a different strategy, a different dose adjustment. But what they have in common is that, differently from atrial fibrillation, when we have a deep venous thrombosis, the risk of recurrence goes down with timing. And as you can remember, in the past, we used to treat patients either for 3 months or for 6 months. And now we're not treating patients for 6 months anymore. The rule is very simple. We treat them with 3 months for peanuts, DVTs, or we treat them for at least 1.5 years for all different DVTs, and I'll show you why. What have we learned with the DOACs? Well, if we treat patients with DOACs, it is the same efficacy of heparin and vitamin antagonists, but with less bleeding, particularly intracerebral less bleeding. That's why we prefer to treat our patients with DOACs. And that's the beauty of the thing, if we extend beyond 6 months, we have 70% less recurrences without increase in major bleeds. That's why in the last 2 to 3 years, the guidelines changed a little bit in terms of extending the time for VTE treatment. So making a long story short, let us look at the 2016 ACCP guidelines, and I'll give you an update on this guideline. For a simple provoked DVT, we have a young lady who underwent the orthopedic surgery and she got a DVT. We can treat her for 3 months. However, if we had a 60-year-old lady who had the same surgery and she has varicose veins, and her mom had a DVT, it is different. A provoked behaves like a unprovoked. So we treat her for 1.5 years. For all unprovoked, 1.5 years. For those unprovoked with high risk of bleeding, we shorten it for 3 months. Distal DVTs, 3 months. Cancer-associated thrombosis, as long as the cancer is active. Upper extremity DVT, 1.5 years. So look, we don't have 6 months anymore. So making a long story short again, simple DVTs, 3 months. Complicated DVTs, 1.5 years. Risk of bleeding, we shorten the treatment. Distal, why this thing changed? One of my students, a PhD student, we submitted all distal DVTs to angio CT scans, and guess what? 80% of them do have pulmonary embolism associated. So this changed guidelines. So distal DVTs, we treat for 3 months if D-dimer is positive, or we have an extension of the thrombus, or close to the popliteal vein, no reversible risk factors, cancer, in hospital, history of DVT, meaning all distal should be treated 3 months. Can we treat for 3 months complicated DVTs? Not a good idea. This is the work of Clive Kieran. He was the spearhead for the guidelines. He died last year due to prostate cancer. But his curve is this one. When you withdraw anticoagulation for a VTE management, you increase the risk of recurrence. So now what we do, we treat simple DVTs for 3 months, and those more complicated DVTs at least for 1.5 years, with a tendency to treat them for more time. Who are at risk of bleeding? Elderly, patients who previously bled, cancer, metastatic cancer, renal insufficiency, liver failure, thrombocytopenia, previous strokes, diabetic patients, patients on antiplatelet therapy. So for these patients, we trend to decrease the timing of anticoagulation. Can we use the dimer to guide anticoagulation? No, that's the very simple answer. It works for women, it doesn't work for men. So this is very intuitive. Everywhere in the world come to me and say, hey, I checked the D-dimers, if it's low level and we have recanalization, we can withdraw anticoagulation. It is nice, it is intuitive, but it doesn't work. It works a little bit for women, it doesn't work for men. Same for ultrasound. Our Italian colleague, Professor Paolo Prandoni, first, he defined what is recanalization, and using 60% recanalization, we randomized patients, and guess what? It works for women. So if you have recanalization and low D-dimer levels, low rates of recurrence, it doesn't work for men. Very high rates of recurrence if you use recanalization and D-dimers. So simple message, don't use that to define time of anticoagulation. So simple case. This lady, 65-year-old, a little bit obese, last month was submitted to a laparoscopic cholecystectomy. She received 2 shots of enoxaparin and discharged from hospital. This month, she arrives with a popliteal DVT. Very simple, very provocated DVT. So if we go to the guidelines, we should treat her for 3 months. This is a CCP. If we follow the European guidelines, we should treat her for 1.5 years. Why? Because when we performed the Einstein choice study and we enrolled more than 3,000 patients, we looked at 20 versus 10 milligrams of Riva. We learned that it decreases recurrences, no, it doesn't increase major bleeds. But we learned that Provoked DVTs with persistent and transient risk factors, they do behave exactly in terms of recurrences like unprovoked. So for this lady, we need to treat her for 1.5 years. Okay, so if we follow the European guidelines, 1.5 years, we are prolonging the treatment time due to risk factors. Cancer patients, this is from Chicago lady, 63 years old with cervical cancer. She underwent 4 lines of chemotherapy. She's not doing well with metastasis in her lymph nodes in the inguinal area, but she has resources. She went to the MD Anderson and she was submitted to the THROMBOSIS surgery where you change the neutrophils to specifically fight her cancer. And guess what? She's getting better, but she arrives at the ER with a proximal DVT, femoral DVT. Everybody would put this lady in the hospital 2 or 3 years ago. Now we're treating them home. Why? She has a very nice creatinine clearance. We just put in hospital patients with risk of bleeding and need for fibrinolytic therapy. So following now the new guidelines, we can treat her with DOACs. Based in what kind of data? We have plenty of data now that we can treat cancer-associated thrombosis. First paper, ours, 2016, 400 patients treated with rivaroxaban, very low levels of recurrences. Then Dr. Kekar provided us with a selected trial. It works, but increases a little bit gastrointestinal cancer. Gary Raskop, Jeff Whites performed the Hokusai trial with edoxaban. It works, but increases a little bit gastrointestinal cancer. And Giancarlo Agnelli last year presented us with a Caravaggio trial with apixaban, showing that it works and it doesn't increase much of gastrointestinal bleeds. So simple message for cancer. You can treat with DOACs, but pay attention with those patients with esophageal cancer and gastric cancer. So now, guidelines, very updated, European guidelines. Antiphospholipid syndrome, vitamin K. For all other DVTs, extend the treatment for those with not identified risk factors, with persistent risk factors, and even with transient risk factors. And we can treat cancer with DOACs, no problem. This is very updated, and ASCOS is recommending the same thing. Our problem now, today, is what do we do with those massive cancer-associated, COVID-19 associated thrombosis? I'm seeing 2 cases of arterial thrombosis a day and 6 cases of DVT a day here in Brazil. We have reached yesterday the very sad rate of 4,000 deaths a day in the country. Our hospitals are packed, we're not sleeping, and in some cases, anticoagulants simply doesn't work. So this lady on the left side, a phlegmasia ceruleus dolens, in 6 hours, fully anticoagulated, no response even to our TPA, and very common arterial thrombosis as well, very tough to treat them. We're thinking about different strategies, very high mortality rates. We're now providing these patients with monoclonal antibodies, convalescent plasma, full plenty dose of heparins, our TPA, and IL-6 inhibitors. We're trying to decrease mortality to these really severe DVTs we're seeing here. And I'm part of so many trials. This one, we're testing interleukin-17 inhibitors, low dose of IL-2, colchicine, and corticosteroids for really sick COVID patients. And a subgroup of this trial, we're going to take a look in terms of improvement of all these thromboses. As of now, Dr. Ayman, I'm running 62 clinical trials, 18 of them COVID-related. We are rushing to gather data because we are in the epicenter of this crazy pandemic. And this is probably my almost final slide. It's our platform here in Brazil for anticoagulation trials. We just finished the ACTION trial where we randomized patients to full anticoagulation strategy versus standard of care looking at mortality. 600 patients. We will present it at the ACC in the late-breaking clinical trial on April 17 now. It's ready. We're seeing the final numbers tomorrow. I'm leading the Michelle trial where we're giving patients discharged from the hospital, either Riva-10 or placebo, and we're looking at both venous and arterial events. And we're doing 2 very interesting trials. One is called CARE trial, where we're giving patients at home either rivaroxaban or placebo, looking at mortality and need for hospitalizations. And we are also testing apixaban in a trial called Apollo. It's a global trial. It's Pfizer sponsored, and we're enrolling 1,000 patients. When we finish all these 4 trials in less than 3 months as of now. And I'm very proud to say that my Iranian folks, Dr. Pahan Sadenipur, that I met in the IUA Young Vascular course some years ago, and I had the pleasure to travel to Iran, invited by their government to teach them how to do clinical trials. And we planted the seed 3 years ago, and look, my Iranian folks, I'm so very proud of them. They published last week the Inspiration randomized clinical trial at JAMA, showing that intermediate dose of prophylaxis with enoxaparin doesn't work as compared to standard dose. Very important question answered by Iranian folks, bringing data to the world. And it was a seed we planted there out of the IUA. I'm very proud of them. They published at JAMA. And I finished my presentation saying that without data, you are just another person with an opinion. We're seeing loads of opinion, but quoting Tom Cruise on the Jerry Maguire movie, he used to say, show me the money. And I tell my folks, show me the data. I don't want your personal opinion as of now. And this is my Instagram. Those who want free education and anticoagulation, every week I'm presenting something new, interviewing PIs of important trials. And from June, it's going to be in English as well. So having said that, Dr. Ayman, I finish my presentation here, and I'll be happy to take any question you might provide to me.
Thank you, Professor Ramshati. It was a very nice presentation, and it was a crystal clear. In the next couple of minutes, I will try to give a few words in Arabic language to our colleagues to make them following us more easily. تحدث البروفيسور إدواردو راماشوتي عن طرق علاج جلطة الأوعية الدموية، وأضاف سيادته أن العلاج يمتد ل3 أشهر وقد تمتد الفترة لأكثر من 1.5 سنة طبقا لعدة معايير واختلاف المحاذير، والفيصل هنا الموازنة بين خطورة النزيف وارتجاع الجلطة، خاصة في المرضى الذين يحملون عوامل خطورة متعددة. والسؤال المطروح الآن، هل يمكن الاعتماد على نسبة الدي دايمر فقط لإيقاف العلاج؟ الإجابة بالتأكيد لا. قد يعمل الدي دايمر في حالات السيدات، ولكنه غير فعال بنفس النسبة في المرضى من الرجال. وهناك أيضا الاعتماد على نسبة الشفاء من الجلطة بالأوردة، وإذا وصلت هذه النسبة إلى 75% يمكن الاعتماد على هذه النسبة مع سلبية التحاليل الدي دايمر. وكما سبق القول أن بروفيسور راماشوتي يجري الآن أكثر من 60 دراسة ميدانية، 19 منهم تتعلق بمجال التجلط في مرضى الكوفيد-19، أشهرهم ستراك ترايل، وتعتمد هذه التجربة على استخدام بعض الأدوية المضادة للتجلط مثل المضاد للالتهاب مثل الكولشيسين. كما هناك بعض التجارب التي أظهرت نتائج إيجابية مثل ميشيل ترايل، ويفخر سيادته بأبولو ترايل التي تم إجراءها على أكثر من 2000 مريض في البرازيل، وبعض الدراسات أيضا في إيران التي سبق أن نشرت في مجلة JAMA. هذا ملخص للكلمة التي أبقاها سيادته. This is a summary of the few a little of the great ideas and thoughts of Professor Ramashwati, and I am honored to introduce Professor Abdul Basit, Professor of Sports, Faculty of Sports. to comment or give a question for Professor Ramashotti. Professor Abdelbasit, please unmute yourself. Professor Abdelbasit, are you ready?
Yes, أنا مش عارف أدخل يا دكتور أيمن. أنا مش عارف أدخل.
حضرتك موجود فعلا.
احنا سامعينك يا دكتور عبد الباسط.
سامعني؟ طب أنا بس هو سؤال بسيط جدا. أولا اسمحوا لي أرحب بالسادة المشاركين في الندوة والحضور والعلماء الأفاضل. يسعدني ويشرفني إني أشارك معاكم. وهو معروف علميا ان كوفيد 19 له بعض التاثيرات السلبيه على الجهاز العصبي وعلى الاوعيه الدمويه وخصوصا الجلطات زي ما شرح العديد من العلماء حاليا في الندوه. السؤال اللي يجب ان نركز عليه في المجال الرياضي، هل من توصيات خاصه بخصوص عوده الرياضي بعد الشفاء من الاعراض انه يقدر يمارس التدريب من حيث نوعيه التدريب او المده الزمنيه او الشده حتى يمكن تاهيله والعوده لممارسه النشاط الرياضي بامان وباسرع وقت ممكن. شكرا لحسن استماعكم للسؤال. تفضل يا دكتور عيد.
Professor Ramashotti, Professor Abdelbasit is asking in those athletes who received anticoagulation during their infection with COVID and on return to complete physical activity, do you recommend the special ideas or recommendations how they can practice the in-person sports, especially football players, fencing, and other sports that will have personal contact?
Well, one number rule is to keep social distancing. So in the very beginning, in the infection, at least 14 days, they should not be in contact with other people. From the clinical standpoint, what we're seeing here, and I took care of some athletes, as long as they don't have short of breath and they are fully anticoagulated, they can return to their activities. We don't see a correlation between activities and recurrence of DVTs. However, a fair number of COVID patients, they are developing myocarditis. So I strongly advise our folks to check with a cardiology system. And if you have the proper image exams and biomarkers, you should check for myocarditis. And in this situation, we should wait until the patient fully recovers his cardiac function, and is taking around 3 to 6 months in athletes here in my country. So I think if the patient does not have issues like myocarditis nor other cardiovascular complications, in 2 to 3 months, it is enough to resume their activities in sports, as long as they didn't have events. And if they have events, they can follow up this time, but they should be on anticoagulants.
Great. Now I would like to introduce Professor Ihab Nabil. Professor Ihab is the Dean of Diabetes Institute in Egypt, and he is the Vice Governor of Rotary in Egypt. He is going to give us a sneak peek about the role of Rotary in joining and dealing with the community, and give a comment for Professor Ramashotti. Dr. Ihab, please unmute yourself.
Hello, dear professors. First of all, I'm very glad to be among the esteemed professors in this magnificent topic that it's quite challenging and that it's very important for all of us as vascular surgeons to discuss and to be aware of. Professor, you're all welcome among the sunny Egyptian weather. On the behalf of the District Governor 2451, District Governor Osama Ahmad, as an Assistant Governor of the Rotary in Egypt, I welcome you all here. And I would like to, as a vascular surgeon, express how much I'm grateful to Dr. Eduardo for such a great, magnificent highlighting issues, and the paramount, the guidelines that you have mentioned are very important to realize. Me, myself, I think that knowing that D-dimer is not the issue for further anticoagulation and to detect the anticoagulation as the sole player is a very important issue that we should all highlight and we should all follow clearly. However, I would like to ask you, sir, in the great problem of COVID-19, what are the parameters that you rely upon to stop or continue anticoagulation? That's my first question. And my second question, in cases of active cancer patients who are taking and receiving DUAC treatment, what about active cancer patients with GIT or UTI, urinary tract cancers? Do you carry on DUAC or do you shift them to low molecular weight heparins? Thank you, sir.
Okay, Professor. So I'm going to the second question that I could understand it here. We take care with both types of cancer, gastrointestinal and genitourinary. Genitourinary, we're not so much concerned because the bleeds we saw in the trials were very manageable. The problem is the gastrointestinal cancer, and I strongly advise you to take care of esophageal cancer and gastric cancer. You can treat patients with colon cancer, it's not a big issue. For these patients, treat them with heparin, enoxaparin. But at some point, they will receive surgery and they will have this cancer removed. Then you can keep the treatment with DOACs. That's the very simple message to deal with cancer-associated thrombosis and gastrointestinal tumors. For genitourinary tumors, don't worry much. You can treat them. It's not a big deal. The first question, can you repeat it? I can't remember the very first question of yours.
Yes, sir. It was discussing the parameters that you depend upon to stop or continue anticoagulation for COVID patients after highlighting very clearly a very important message that D-dimer is not the parameter to rely upon.
Well, Professor, this is a superb question. In the beginning of the pandemic, we thought that COVID-associated thrombosis would be a provoked thrombosis, and then we could treat these patients for just 3 months. And it was catastrophic. Believe me, we treated young people here for 3 months, and we're seeing very high rates of recurrences. So as of now, that we don't have much data, we are trending to treat COVID-associated thrombosis for at least 1.5 years, giving us time to gather data if it is enough, or we should even prolong it. Why? Because COVID is the most prothrombotic disease we ever seen in life. And it comes out with an endothelitis that we don't know for how long it would take to heal. We're seeing patients discharged from the hospital in really good conditions and returning after a month with arterial thrombosis or stroke or cerebral venous thrombosis or deep venous thrombosis. So as of now, treat them for at least 1.5 years and give us time to gather more data. Very important question, Professor.
Thank you, Professor, very much.
I have a question from the floor. Dr. Suhail Naguib from Egypt is asking regarding the canalization percentage of the vein and the D-dimer, both could not be reliable in treating VTE patient, male patient. He is asking what we can follow in such male patient.
Okay, so if you have to choose something to follow, I strongly advise you to follow the creatinine clearance. The creatinine clearance is the new INR for us vascular specialists in terms of follow-up anticoagulation. It is more important than anything. So, in a male patient that has a first episode of a DVT, you can do the ultrasound, you can do the D-dimer, but they will be useless in terms of defining the time of anticoagulation. So as of now, if it is a proximal DVT and the patient has other comorbidities like obesity or previous history of DVT, first episode, treat this patient for 1.5 years and even prolong it if you feel he has a risk of recurrence. 1.5 years, despite the D-dimer, despite the ultrasound, and you can prolong it. However, forget the D-dimer, forget the ultrasound. If this patient has 2 points in the risk factors for bleeding, shorten this treatment and follow up the patient. Well, something goes wrong, and after withdrawing the anticoagulation, this patient has another DVT episode. Now you're going to treat him forever. You're going to treat him forever after the second episode. Okay?
Great. Thank you, Eduardo. And it is a very good and very interesting interacting discussion. Thank you, Eduardo. It was great. Now I think we have to give the mic to Professor Antoniani. Professor Antoniani is the president of International Union of Angiology and professor of angiology, University Esperanza di Rome. Is going. Do you would like to share your screen, or we give the film?
Use my video, please.
Okay. Will use video.
Thank you. Because I don't have a good connection, so it's better. It's better. Thank you.
Great.
Thank you, Imam, for the invitation and welcome to all speakers. It's very difficult topics.
Till we have the video, I think Erica wants to give a comment. You want to give a comment, Erica, for Eduardo?
Yes, thank you. Thank you. Yes, Eduardo, thank you for this wonderful work and this impressive amount of investigation you perform. I didn't listen you talking about aspirin, and I think a group found that the patients with COVID have antiphospholipid syndrome and it's arterial thrombosis. And why didn't you study aspirin in the prophylaxis? I mean, I am trying to do this in Germany, but it is so difficult to make a study on preclinic patients, you know, those infected and with little symptoms or nothing of symptoms, to give them aspirin versus placebo to look if the thrombosis could be avoided, because arterial thrombosis are better avoided with aspirin, and DOACs don't work as good in antiphospholipid syndrome, and it is 50% of them that have antiphospholipid antibodies.
Well, Professor, this is a nice question. And my simple and direct answer to you is that I have just 2 arms and 2 legs. And despite of having 48 young people helping me out, what we did, we divided among the small community of anticoagulation folks the work. So my American folks are studying antiplatelets. I'm running just 1 trial with the French folks. We're testing a monoclonal antibody that blocks the factor 6 of platelets. It's called glencizumab. And I'm helping them with the phase 2. They have this very strong impression that is platelet-induced thrombosis. And I agree with them. So from this standpoint, we're studying this monoclonal antibodies. American folks are studying clopidogrel and other antiplatelets agents, as well as aspirin. And as you can remember, I believe that World Health Organization trial looked at aspirin and it showed a trend to reduce mortality.
Okay.
So we're dividing things. Yeah, we're dividing things. I believe aspirin should play a role, and you are correct. We have 2 major causes of thrombosis. One is the endothelitis. Number 2 is direct infection of the virus on the platelets, increasing its reactivity and increasing the liberation of cytokines. From the antiphospholipid syndrome, we believe that is a false negative because of the endothelitis.
Okay.
So we see 27 to 53% of antiphospholipid patients positive for these antibodies, but we could not figure out why it should induce, because the other two measurements, the antiphospholipid antibodies and anti-beta-2 glycoprotein is negative with them. So probably it is a false negative induced by the endothelitis. Nevertheless, we're dividing the work. So American folks are studying aspirin, and you are totally correct. Probably it plays a major role, and we're expecting this data as well.
Okay, thank you.
Thank you, Erika, and thank you, Eduardo. And now we are ready for Professor Antoniani.
Thank you.
The video is ready.
I don't see. Okay.
Thank you to organizer and Professor Fakhri for the kind invitation. This is my disclosure. The COVID-19 induced complement hyperactivation, endothelial dysfunction, and cytokine storm, with a consequently prothrombotic effect. The COVID-19 patient developed a procoagulative state directly related to disease severity. Lung are the most affected organs, and a critically ill patient often show thrombotic lesions in pulmonary macrovessels, with a prevalence twice higher than critical non-COVID-19 patients. Therefore, the correct management of the anticoagulant therapy in this patient has a fundamental role. This is the cytokine storm, and together with the complement cascade hyperactivation, they play an important role in the hypercoagulable state of a COVID-19 patient and are the rationale for the use of anti-inflammatory drugs and anticoagulant as heparin. The use of anticoagulant, mainly in critical patients, is not free from risk and may be related to severe hemorrhagic complication. The indication of anticoagulant should be personalized, respecting thrombotic and hemorrhagic risk profiles. Anticoagulant therapy in patients with severe COVID-19 and signs of sick and/or very high D-dimer in association with other markers of severity in absence of a contraindication to anticoagulation can be considered a therapeutic strategy for COVID-19 infection. This strategy requires the use of strict institutional protocols that enable surveillance and rapid intervention if a complication occurs. The possible benefit for attenuating the hypercoagulable state should be balanced against the risk of bleeding. The anticoagulant therapy may be more beneficial when initiated in a pre-thrombotic stage and not in advanced phases. If deciding to use anticoagulation, low molecular weight heparin should be chosen for stable patients with normal creatinine clearance. In conclusion, the expert consensus suggests anticoagulant treatment for patients with a procoagulant phenotype. This is an example of a tailored algorithm for the management of coagulopathy in COVID-19 patients. This is another proposal of anticoagulant treatment. It is an algorithm based on the evaluation of different scores, Padua or Caprini scores. With a wide range of disease expression and a broad scope of clinical severity, COVID-19 presents a different challenge for each patient returning to activity. These may include the recreational jogger with noticed persistent fatigue and the swimmer who suffers ongoing respiratory symptoms. Different from professional athletes who have existing medical programs to guide return to activity, recreational athletes often return to activity in conjunction with the primary care provider. We know that the physical inactivity is well recognized as risk to physical and mental health that is associated with increased all-cause mortality. The effect of inactivity can rapidly change the body metabolism. The effect of this relative inactivity is important to consider when examining the risk of a chronic disease expression due to relative inactivity. The occurrence of venous thromboembolism in athletes has been described in literature. They often are subject to trauma, embolization after trauma or surgery, frequent long-distance travel, and other factors which increase the risk of venous thromboembolism. Mainly the athletic that use the contact sports. When the new oral anticoagulant are available, individualized treatment plan, also in contact sports, can be developed to allow for participation with only a small increase of risk. We know that the COVID-19 has resulted in significant morbidity and mortality around the world. The majority of patients fall in the middle to moderate category, with symptoms lasting less than 6 weeks. But the morbidity from COVID-19 is significant and can affect multiple body systems, most frequently the cardiac, pulmonary, hematologic, musculoskeletal, and gastrointestinal system. Regarding the cardiac system, we can see arrhythmia, myocarditis, and acute myocardial injury. Systemic inflammation is due to the cytokine storm, and hypoxia are some of the proposed mechanisms in the multifactorial pathophysiology. Many non-hospitalized individuals with COVID-19 will likely not develop cardiac manifestation and be able to safely return to exercise. Regarding return to sport, recommendations vary in extent of recommended testing prior to return to play. Some authors suggest return to play for athletes with COVID-19 after resting from sport for at least 10 days after symptom onset and 7 days after symptom resolution. Regarding the pulmonary system, there is the acute respiratory distress syndrome. This is the major pulmonary complication in patients with severe diseases. According to World Health Organization, the median time for symptoms onset to clinical recovery is approximately 2 weeks, and 3 to 6 weeks for patients with severe or critical disease. The guidelines published in the Lancet Respiratory Medicine recommend the prolonged rest after infection, 10 or more days from symptom onset, plus 7 days for symptom resolution. These recommendations, however, don't address those with more severe disease manifestation. In this patient, it's very important to monitoring the pulmonary conditions. Regarding the musculoskeletal system, we can find myalgia and arthralgia, and also muscular fatigue. This fatigue is commonly reported in addition to myalgias and may last for weeks. In this case, the corticosteroid injection should be used with caution during the pandemic condition, and when necessary, we suggest using betamethasone and dexamethasone. From this musculoskeletal perspective, return to exercise in patients recovering from COVID-19 should be guided by symptoms, while symptomatic patients should avoid intense exercise. Low-intensity exercise for 1 week is suggested before returning to more rigorous exercise. The hematologic system is interested from the infection. And it is recommended that the patient currently receive anticoagulation or antiplatelet therapy continue their medication as prescribed if they are diagnosed with COVID-19, and that anticoagulant antiplatelet therapy not be initiated in the no-hospitalized COVID-19 population. Hypercoagulability if of concern in the athlete returning to recreational sport after COVID-19. While exercise is not currently recommended in someone acutely symptomatic with COVID-19 for several pulmonary and cardiac reasons, low-intensity exercise, or at least avoidance of prolonged sitting, may offer some protection from hypercoagulability tendencies in the non-hospitalized asymptomatic or mildly symptomatic COVID patients. Some patients with COVID-19 develop gastrointestinal symptoms such as vomiting, nausea, anorexia, and diarrhea. Fluid and calorie intake should be monitored through the symptomatic phase of the illness as well during symptom resolution upon return to activity in the recreational athlete. The exercise capacity and health status of the survivor to COVID-19 were considerably lower than that of the normal population at 6 months. The functional disability appears disproportionate to the impairment lung function and may have related to muscle deconditioning and steroid myopathy. The COVID-19 patient should be followed closely, especially in the first 3 to 6 months as they return to exercise program. This is true for athletes who have had COVID-19 to any degree. This will be adjusted by the severity of the disease and may require the gradual return to activity occurring over many months rather than weeks. Given the rapidly evolving scientific landscape surrounding COVID-19, guidelines for safe return to recreational exercise is likely to change. Consequently, there is a need for providing a framework and a preliminary recommendation for safe return to exercise based on current knowledge. Thank you for your attention.
Thank you, Professor Antoniani. It was a great talk. In a couple of minutes, I will give the summary in Arabic for our colleagues. أتوجه بالشكر للجنة المنظمة لورشة العمل والدعوة الكريمة الموجهة لي. كما هو معلوم أن مرض كوفيد-19 من الحالات التي تزيد فيها نسبة حدوث التجلط في الشرايين والأوردة. تتمثل خطورة هذا المرض لإطلاق منصة السيتوكاينز والتي تؤثر على جميع أجهزة الجسم، ولذا يجب استخدام الأدوية المضادة للالتهاب للتقليل من الإصابات الناتجة من إطلاق تلك المنصة، واستخدام مضادات التجلط مسيلات الدم في مثل هؤلاء المرضى يجب أن يختلف من شخص لآخر طبقا لمعدل الإصابة وتحليل المريض مثل الدي دايمر والعوامل الأخرى، مع مراعاة عدم وجود عوامل أخرى تمنع استخدام هذه العقاقير. ومن ثم يجب مراعاة التوازن بين زيادة فرص التجلط مع خطورة النزف لهؤلاء المرضى. والخلاصة أن استخدام مسيلات الدم للمرضى الذين يعانون من ارتفاع نسبة الدي دايمر وجزيئات الفايبرين بالدم بالاعتماد على معامل كابريني يمكن أن نحدد بسهولة هؤلاء الأكثر تعرضاً للإصابة بالتجلط، ويمكن التعامل معهم على هذا الأساس. ويجب أن يقلل الجهد المبذول لهؤلاء المرضى خلال الأسبوعين الأولين من المرض، ومع بدء العودة لمعدلات الحركة للرياضيين المصابين بالتجلط خلال الأسبوع الثالث والرابع من الإصابة، بعد أن يتم تحديد معدلات الحركة في الأسابيع الأولى. وتتمثل شدة الإصابة بمرض كوفيد مرحلة متوسطة من التأثير على أجهزة الجسم المختلفة تمتد لمدة حوالي 6 أسابيع، ويعد الجهاز التنفسي والجهاز الدوري الأكثر تعرضاً للإصابة في هذه الأحوال. وتوصي المراكز الطبية بالراحة للمصابين من الرديين لمدة 10 أيام من الإصابة أو 7 أيام من اختفاء الأعراض، كما يوصى بالعودة بعد أسبوعين للرياضة التدريجية والتنافسية. وأضافت القواعد المنظمة لهذه اللجنة مع متابعة الجهاز التنفسي لهؤلاء المرضى. فقد لوحظ أن 15% من هؤلاء المرضى يعانون من ضغط عضلي وضعف بعضلات الجسم، وتحتاج لعدة أسابيع للعودة للحالة الطبيعية مع تدريبات متدرجة. أما بالنسبة لإيقاف أدوية السيولة فهذا يتوقف على عدة عوامل معظمها فردي ولا يمكن تعميمها، وهي متابعة هؤلاء المرضى عن كثب ولمدة 6 أشهر مع العودة التدريجية للحالة الطبيعية والممارسة التدريجية للنشاط الرياضي. Now I introduce Professor Ayman Farghali, Professor of chest and the ex-president of Karate Federation, and I think he has to give his comment and discuss something with Professor Antoniani. Please unmute yourself, Dr. Ayman.
Well, I would like to thank the previous two speakers actually for the very meticulous and actually to the point talks, but I think we need to discriminate here some ideas. First of all, not every COVID patient is going to have anticoagulation. But according to the guidelines and what we have accumulated data now, most of the cases, they are not going to take anticoagulants. So we are dealing here with the high performance athletes who have mild symptoms or asymptomatic. People are not going to take anticoagulants, so no problem with them. The issue is the severe cases that are going to the hospital and ICU, and the majority of these patients, according to some of the risk factors, they are going to have the anticoagulants. Well, now, are we going to get these athletes back to exercise? I'm talking about high performance athletes. While they are taking the anticoagulants for the late 3 months, this is my question. They are fully anticoagulated. Are we going to let them go through the heavy duty exercise? I think this needs some discussion. And also I know there is no great consensus on this point, but I need to hear from the previous speakers. What do you think about the high performance athletes on anticoagulation after severe COVID?
Professor Antoniani, can you discuss?
But the problem of athletes is a very big problem because they wish to start with their activity immediately. But we have to consider the complication of the COVID-19. And the main leontis is in the pulmonary system, as you know. So the athletic activity requests a very good activity of a pulmonary system. So I think there is a different categories of patients. Of course, asymptomatic of little symptomatic patient can start with the normal activity just after 2, 4 weeks is enough to conclude this period of shutdown. But in patient with the middle of severe compromission, is important to reach the complete recovery of physical condition. And according to the literature, the time is 3-6 months to reach the complete performance. This is important also for the team because it's necessary to program the activities, the sport, the activity of teams. Of course, the particular condition is in the sport, contact sport, in which the patient is under anticoagulant, because in this case it is possible to have some trauma with hematoma, and in this case we have to avoid, of course, this complication. I hope to answer your question.
Yeah. So can we come to a statement that the majority of athletes who have COVID and they have mild symptoms, and then we go through the algorithm you have described, after 10 days from symptoms and 1 week of rehabilitation, and also if we don't have myocarditis, the complication that we are very serious and we are aware of. So this patient can go gradually for exercise with less load according to the algorithms described. But the issue is the people who had severe COVID and they required anticoagulation. We need to be very careful when we talk to them to go back. And for me, I think people who are going on prophylactic doses can go for recreational exercise. But on therapeutic doses, I need to be very careful with them and to be with very low doses of recreational, maybe just walking and not sharing in combat and such activities.
Yes, I agree completely with you. Your summary is correct. Thank you.
Great. I have a question from the floor from Dr. Peter Thoma. He's asking about the microemboli at the digit in COVID patient. He's asking what he can do. Use anticoagulant for such patients or thrombolytic therapy for such patients?
But if there is a condition, a microcirculatory condition of the two, with the presence of a pulse, probably is a peripheric thrombosis. So in this case is enough the anticoagulation. But of course, we have to identify correctly the condition, because if there is the cyanosis, it is important also the thrombolytic therapy to avoid the amputation of patients, of course. We have to evaluate patient by patients.
Great, thank you. Now I think we can go for Professor Sergio Genesi. Sergio, do you want to share your screen, or we'll put the video?
I will be happy to share. So if you want to make me host, I'm already host, I see. So I think you can see my slides, right?
Yes. Now I'm honored to introduce Professor Sergio Genesi, Professor of Angiology, University of Ferreira. Sergio is the Vice President of UIP, and he is the founder and the president of VWIN Foundation, which is a great organization dealing with a lot of phlebology along the universe, and he is trying to connect the universe. This is fact. It's an honor to have you today, Sergio, and the mic is yours.
Thank you so much, Professor Fakhri, and the honor and pleasure is mine. And I'd like to congratulate for the initiative of gathering on the stage or on the ring, like in the picture, huge figures like the faculty we have today. And indeed, it's an honor to share with them this stage. These are my conflicts of interest. While I declare that indeed the VWIN Foundation that I represent today is extremely interested in this topic, we really created the foundation starting from a call from Lancet Journal that was pointing out how thrombosis is the leading cause of preventable death. And it's interesting to notice today that we are focusing on the athletes, that it is a problem that is touching all the population, and in particular the athletes, as we know from the literature, from tennis, as it happened with Serena Williams, but also to all the other sports where there are huge athletes who have been unfortunately hit by thrombosis indeed. So if we really want to reach out to the audience to dive into the topic of elite sports practice and thrombosis, we know that we can go back to the same Virchow triad, because we know that these subjects are prone to potential conditions leading to stasis like hypotension and bradycardia, rather than specific sport activities associated with a specific positioning leading to compression of a specific anatomical district, like, for example, cyclism. But it's interesting to notice how we have papers showing also how the hydrostatic column of a longer leg, like the one of a basketball player, could lead indeed to an increased risk of thrombosis. We should also remember that all these elite athletes are prone to travel intercontinentally, so we could open the Pandora vase of the thrombosis risk associated with long-haul flights. And there are indeed some data showing the higher risk for these subjects, for example, when we are talking about the runner's world, while we don't have confirmation in other sports. So it's always a little bit of a fragile data analysis, this one, because it really depends on the sport we are looking at. For sure, when we are talking about trauma in sports and consequent also surgical trauma, we are touching 2 points of the Virchow triad, both the one of the endothelium damage and at the same time the post-immobilization stasis, of course. It's interesting to notice that we have also papers that are showing how we can inflame our endothelium with repetitive movements, like, for example, in baseball, who have been associated with the risk of thrombosis. And then we move to the other part of the Virchow triad with the hypercoagulability that has been associated with the use of oral contraception, because we know that, of course, female athletes might have this need, but it is really gender equality when we think about the effect of the anabolic androgenic steroids, and this is a good chance to once again promote no doping in a sport. We know the effect, for example, of erythropoietin. That is not just associated with the problem of doping, because we have literature showing also high altitude sport practice associated with an increased thrombotic risk. The exertion per se can lead in specific cases to higher tendency of thrombosis based on the literature. This has been demonstrated with an increased aggregation, just as I was saying before, in some sports. For example, it was demonstrated in runners, but not in cyclism. So we could discuss a little bit more about the different sports. But for sure, whatever sports we are talking about when we are getting into the agonism of the elite sports, we see that there is an increased risk of thrombosis and even sudden death based on the literature. For sure, these subjects are also prone to develop a DVT that will lead to the loss of time in their career. That is usually pretty short as time in their life. So it's an important topic, I think, since today's audience is the one of the athletes, knowing that 6.7 months is the average time loss for a DVT in the sport world. So it's really important to get ready to face the thrombotic risk by a proper risk assessment analysis of these subjects. It's very important to know their predisposition and also to stimulate them to have a proper lifestyle in terms, of course, of hydration and mobilization, particularly when we are talking about the competitions that are requiring long flights, for which there is an indication of avoiding flights right after the exertion for these subjects. But as I was saying, this is opening a Pandora vase. We touched this point after the last of the Winter 2019 meeting with the consequent publication on similarities and controversies in terms of guidelines also for the thromboprophylaxis during long-haul flights. So this is another topic for discussion, I think, later on. Of course, this is offering the opportunity to start talking about the breathing compression stockings. That was one of the main topics Professor Fakhri asked me to touch in this talk of mine. Of course, they can help. We will see a little bit more about this at the end of this talk. And of course, it can help this subject to have a customized procedural thromboprophylaxis. I didn't jump into the discussion before because I'm going to talk about this now, but of course, I think one size does not fit all in all the different sports we have to face. And of course, the sport athletes of course, are finding themselves in front of many different challenges, because if we're talking about traumatic sports, we know that we have the bleeding risk to take into consideration, as we have the impact of an eventual DVT on the performance of the athletic act, but also on the psychological component, and also, as I said before, the economic impact of a prolonged stop from the activity. I don't want to touch the points that were already touched by the huge experts, Professor Macciotti. It would be interesting, though, to really brainstorm if we want to consider these thrombosis as provoked or unprovoked. We know, as we have listened to already, that we have this 3 months threshold that we want to consider for treatment. My comment on this would be that we have papers showing that it takes at least 3 weeks to have a solid adhesion of the thrombus on the wall. So I would really recommend to be extremely cautious in this range of time. Professor Macciotti already told us that we can go with DOACs with already proven same efficacy compared to VKA and less bleeding also. Interestingly, this paper of Moll is showing that in reality, the recurrence risk of a VTE of anticoagulation following an unprovoked VTE is very low. And for this, when there is the need for athletic performances to have a temporary cessation, we could think, according to this paper, to use intermediate dose of DOACs, in particular rivaroxaban and apixaban, having an evaluation of the pharmacokinetics in the specific subjects. As you can see, they are proposing here the evaluation of the cutoff value of 30 nanograms per milliliter. Another point of view is coming from Nadza, another interesting paper I suggest you to read, that is pointing out, differently from Moll, the possibility of having an active dependent analysis of the calibrated anti-10A and anti-2A assays, having a treatment that is different if you are talking about contact sports versus non-contact sports. I think we have a very interesting webinar today, thanks to the Egyptian Venous Forum, because we could discuss about a lot of things, I think. We have subjects who are exposed to an intensive training, which means also an altered renal function, which means dehydration, which means muscle breakdown, which means a potential effect on the same DOAC metabolism, with also the individual variability to be taken into consideration. Up to my knowledge, we don't really have an identified threshold for minimum DOAC doses for the related bleeding risk. For sure, I think in the future we will have to decide how to monitor at best these subjects, who should be monitored among these athletes. As I said before, should we consider provoked or unprovoked these kind of thrombosis, and which kind of exertions we are taking into consideration, and the potential activity on the dog's efficacy. And of course, we will have to evaluate the different activity of the dogs in terms of performance in the different sports. So of course, I'm just a little baby compared to the huge experts who are sharing the ring today. So I really congratulate once again all the faculty. We have, of course, another challenge now with COVID. For this, with the WIN Foundation and a lot of experts, we deeply thank. We created educational videos that are available for free. So if the athletes want to have a look at that, because we know that indeed there is a significant increase the risk, so much that now the scores are including an update like the one of Caprini for COVID itself. We have also other opportunities that we didn't talk about yet. And for example, the use of surodexide, that is dermatan and heparan sulfate, as an alternative for these subjects, considering also the fact that it is orally bioavailable and it has demonstrated the possibility of reducing the recurrence after thrombosis. And recently, just a few days ago, it was also published that thanks to its use, there was a reduction in terms of hospital admissions and oxygen support. So another topic to be added in the list of things we should discuss about, together also, of course, with the diet interaction, considering the specific nutrition regimens of the sport guys, the importance of the enhancing drugs that sometimes are used, and the potential interaction on the coagulation system, same for the analgesics that sometimes are used in the sport world. And also the fact that we haven't talked so much about the role of BMI if we consider, for example, sports where we have huge muscle masses, and also the role of the menstrual bleeding that could be an issue for these athletes. Going toward the conclusion of the talk, to cover also the requirements of talking about compression. This is a nice picture from the wonderful times we shared in the past during congresses with great colleagues and friends. I was joking around the fact that we don't know if we are wearing or not stockings over here. If we look at the literature, for example, we have a paper showing that there could be a significant improvement using proper compression in the parameters you see reported over here. But it's important, I think, to clear our minds on what is fake news and what is not, because there is a huge market that is quite lucrative, but not so much evidence-based, unfortunately. So it's our responsibility to really put some light on the topic. If we look at the systemic reviews, we see that there is a clear demonstration that stockings, proper compression stockings, can help in terms of delayed onset muscle soreness, but commercials like this one should be stopped because we really need more evidence before claiming so many benefits. For example, there are papers like this one showing in a half Ironman triathlon race not significant benefits. While we have other papers that are showing, like in this case, a significant improvement in runners. So we really have to dissect the data properly. If we look at some objective data of proper compression, we see that there is a potential great benefit, for example, in the control of the fatigue with a 30 millimeter mercury that is relieving the triceps sore fatigue versus 18 or versus a sham. We published this paper recently showing the importance in healthy subjects of a proper sizing of compression, because if not, we get the risk of having a lot of inappropriate compression. We touched in this other publication the topic of flights and the important impact on edema control, also with mild compression, dividing the leg in different sectors, so really analyzing the edema shifts inside the compartments of the leg. In this other publication of our group, we demonstrated the impact on the perceived exertion with a validated scale that is called Borg's scale, that showed indeed a benefit walking with a proper compression in healthy subjects, and this could be of interest for the athletes. But interestingly, we didn't find so much literature at the time in terms of comparison of continuous versus intermittent walk. And this is quite important if we consider that our patients are walking downtown intermittently, not continuously. For this reason, we made another publication on golfers, so again, athletes, randomizing them in 23 versus 18 versus a sham, and showing once again that proper compression at 23 millimeter mercury was able to control the perceived exertion, while 18 and sham were not. Of course, we should talk about the different sport activities with the different use of stockings, because we have sports like basketball where there is an improvement according to this paper. Same thing for volleyball with a particular improvement for the female. Even in the upper limbs for sports on the wheelchairs. But we have also fake news like this one showing that compression is not beneficial so much that the soccer players were cutting their socks. But of course, this is not certified stockings. We know from the cycling world that the benefit can be so significant to be considered doping from some athletes associations. So we should really investigate a little bit more this topic as well. And of course, we should first of all stop uncertified product use with false claiming like this one that really need support from evidence-based data. For this, I invite you to visit the page dedicated to education to the patients. There will be also a raffle prize that will lead to the presence of the winner to the next winter meeting that is always associated to sport initiatives, in this case in Dubai during the Expo, where we will co-work also with the Egyptian Venous Forum, who I'd like to deeply thank for the creation of a consensus document that will be presented indeed during the Expo. in Dubai. I look forward for seeing you in 2 days for the Vein Week, where there will be a lot of sport as well, with the volleyball in particular case of the American Beach Volley Association. So thank you so much, Ayman, for the great initiative. I hope it's just the first of many other with the sport world.
Thank you. Thank you, Sergio, for this great talk. This is very comprehensive and well illustrated, and allow me for the couple of minutes to make an Arabic summary for our colleagues. اسمحوا لي أن أتوجه بالشكر للجنة المنظمة والجمعية المصرية لعلوم الأوردة والجمعية المصرية لعلوم جراحة الأوعية الدموية. هناك الكثير من الرياضيين الذين تمت إصابتهم بأمراض التجلط، وأشهرهم سيرينا ويليامز. وهناك ارتباط بين التجلط والتخثر، خاصة في أوضاع محددة مثل أنواع مختلفة من الرياضيات كراكبي الدراجات، وحيث أن هناك علاقة مباشرة بين إصابة الغشاء المخاطي وبعض الرياضات، كما أن هناك علاقة بين الرياضات مثل البيسبول وممارسة الرياضة في المرتفعات، وتعرض الرياضي المتكرر للسفر المرهق والطويل. ويحتاج الشخص العادي إلى 6 أو 7 أشهر للتعافي من آثار التجلط، وهناك فترة للنقاهة من هذا المرض، وهذه فترة ليست بالقصيرة بالنسبة للرياضي. ويمكن أن نرسم خارطة الطريق للرياضي للوقاية من التجلط، تتمثل في مراعاة عوامل الخطورة لإحداث الجلطات، واتباع معامل تقدير الخطورة الفردي للتجلط لبروفيسور كابريني لتحديد درجة الخطورة والمعامل المناسب للاستخدام لمثل هذا الرياضي. كما هناك دراسة بعض العوامل المتوارثة والتي تزيد من نسبة حدوث التجلط، كما يجب مراعاة التحرك المستمر للرياضي مع تجنب عوامل نقص السوائل والجفاف. كما نصح سيادته بعدم السفر بعد ممارسة الرياضة العنيفة مباشرة، بل يجب الانتظار لمدة 24 ساعة على الأقل. ويمثل لبس الشراب الطبي أهمية عالية لتقليل هذه النسبة من الإصابات. والآن هناك توازن بين العلاج باستخدام مسيلات الدم بين النزف والتجلط، ويجب مراعاة عدم حدوث نشاط رياضي قبل شهر من حدوث الجلطة لضمان ثباتها. ويجب استخدام مسيلات الدم الحديثة عن طريق الفم كوسيلة آمنة وفعالة لعلاج التجلط وعدم تكرار الإصابة، خاصة في الشهور الثلاثة الأولى. ونواجه الآن تحدي كوفيد-19، وأظهرت التقارير أن حوالي 4.5 من المرضى يصابون بجلطة باردة الساقين خلال مراحل الإصابة بهذا الفيروس. واستطاع البروفيسور كابريني تعديل معامل الخطورة وإحداث معامل خاص لهؤلاء المرضى، حيث افترض أن وجود درجتين للمرضى بدون أعراض، و3 درجات للمرضى بدون أعراض، و5 درجات لحدوث الأعراض مع ارتفاع بنسبة الدي دايمر. ويجب حساب هذه العوامل لكل مريض على حدة، وتقدير نسبة الخطورة وإعطاء الدواء المناسب لها. ومن هنا تتجه الأنظار لاستخدام عقار السولدوكسايد للوقاية من التجلط لمثل هؤلاء المرضى كبديل أو كعلاج مساعد لمثل هؤلاء المرضى. ما زلنا في انتظار النتائج الأولية لهذه الأبحاث. كما أشار سيادته للأهمية من ارتداء الشراب الطبي الرياضي، خاصة لهؤلاء المصابين من مرضى الكورونا، وكما أفاد أن هناك دراسات ميدانية كثيرة تؤكد أهمية لبس الشراب الطبي لتقليل الألم وتقليل التورم للساقين باستخدام الشرابات الطبية المناسبة. وهي مراعاة أن هناك أكثر من نوعية وأكثر من ضغط مختلف، وقواعد منظمة لاستخدام الشراب الطبي وليس استخدامه على وجه التعميم، وليس هناك شراب لكل الأغراض ولا شراب لكل الرياضات. اسمحوا لي أن أتوجه بالشكر مرة أخرى، وأنا أدعوكم للمشاركة مع منظمة VWIN وزيارة الموقع الخاص لهذه الجمعية والتعرف على الإرشادات الخاصة بالمرضى للوقاية من حدوث هذه الجلطات. كما ندعوكم للاشتراك في المؤتمر السنوي في دبي سنة 22 إن شاء الله. Thank you, Sergio. This was a resume in Arabic language. Now I will ask Professor Adil Fathi, Professor of Psychiatry, and he is the ex-chairman of the Athlete Federation, and he's a very famous runner, and he has the great activity, and is a lot of medals in Egypt and along the universe. Please, Adil, can you unmute yourself and give your comment for Professor Sergio?
Thank you, Professor Sergio. Thank you, Professor Sergio, for your lecture. Really, we get too many benefits of this lecture. I think it will be very beneficial for the all the athletes and all the sportmen, all people who are doing the and practicing sport all over the world, not only in Egypt, but all over the world. Thanks for all of you. Thank Dr. Professor Ayman.
Thank you.
I have a question for you, Sergio. Regarding the use of salt oxide, do you think it will replace anticoagulation in such patients?
That is an interesting question, and I will quote the final slide of Professor Ramaciotti when he said, without evidence-based data, it's just an opinion. So it's very difficult to say, of course, without data. What I say is that it is extremely interesting the mechanism salt oxide has in the restoration and protection of the endothelium, because we go back exactly to what Professor Ramaciotti told us before, specifying that COVID is endothelitis, basically. So we have interesting data on the topic under publication, so I hope very soon we'll be able to disclose them. But what I can tell you already is that the bioavailability of the drug, the fact that it is already available, and the preliminary data showed on COVID with the study of Ochoa, who is showing, as I was showing before, a better management of the hospitalization, of the oxygen support, are, I think, leading us to take into consideration also this possibility, particularly considering that the bleeding risk is basically nothing with these dosages. So it would be interesting to investigate more, and I think we have another weapon to take into consideration in this unlucky wartime that we are living in.
I think this will be a great news, and we are all waiting for such great drug may help and solve many problems. I hope it could help more and more. Thank you, Sergio. And
thanks to you, and congratulations for the initiative.
Thank you. And now we are going to listen to Erica. Erica, do you want to share your screen, or we put the video?
I prefer the video because the Wi-Fi is not so good. Yes, the video is ready.
Great. It will be here in a second.
Okay.
And now I introduce Professor Erica Mendoza. Professor Erica Mendoza is a professor of angiology and phlebology in Germany. She is General Secretary of German Society of Phlebology, and she's the President of the German Congress of Phlebology in 2022, and she's a President of the European Venous Forum 2023. Thank you, and we are happy to have you today with us, Erica.
Thank you. Thank you very much.
Dear Professor Fakhri, dear audience, I'm very honored to be invited to this important topic. about anticoagulation therapy, which of course is very important for sportsmen. I have no conflict of interest to declare, and I am a phlebologist. This means that I treat with varicose veins, and thus my interest in thrombosis is very high. And since Corona started and it was obvious that there were lots of thrombosis happening, I was very engaged trying to sort out something to bring a little bit of light into the dark, and had the big help of my big friend Ayman Fakhri. Thank you. So the contents I was requested was, should any infected athlete receive anticoagulation? When to start and to stop anticoagulation? And when does the infected athlete start playing games? So let us just have a look at why anticoagulation in COVID-19. This COVID corona disease induces thrombosis in arteries, especially in the lungs. And this was known already in the early infectious disease stages in Wuhan, where they observed that people receiving heparin on intensive care units were doing better than those which not received it. And it reduced the mortality from 60% to 40% if you gave them heparin. So let's have a short look at what happens in the body when you are infected with corona. So the black box is the body. If you have the transmission of the virus, you get the viral replication inside the body, and this induces the autoimmune system to produce things that will harm us. So it's not the virus itself which is harming us, but it's the response that we have induced in our immune system that will harm us and get us to have a severe disease and to get hospitalized. And at this stage, the effect of heparin and in the meantime, the effect of aspirin is well known. We can, of course, try to avoid getting infected with vaccines and masks. And this phase in between here, this red arrows, is the phase where we have very little information about what happens. But this is the phase when the thrombosis starts harming the person, of course. Just again, a little bit of background information. The corona timeline is the time between onset on the symptoms and hospitalization, which is usually 1 week. The corona timeline is just to show that usually after the onset of the first symptoms, like headache, fever, and so on, and coughing, perhaps loss of smelling function, you have 7 days of development of the illness, and usually day 7 is when you go to the hospital. And if you have a look at what happens in the blood during this time, if you look at this curve, you see that in the first 7 to 10 days, the virus is getting up in the blood, and simultaneously there are 2 things going up: the complete inflammatory process and the proteins that are expressed by the process, and the D-dimer. The D-dimer is what happens when you have a thrombus in the artery or in the vein, and the body is destroying the thrombus to defend and to protect himself. And then these D-dimers go up in the blood, because this is the fragmentation of the thrombus by the body himself. So the higher the D-dimer, the more thrombosis you have. And if you have a look, what happens if you give them heparin after days 7 to 10, when they go inside the hospital and they are very ill? These D-dimers go down again, and with the D-dimers, the inflammation markers. So D-dimers and inflammation go very close together, and you can influence the inflammation markers, avoiding the thrombosis, which is very important in this disease. To sum up, corona-induced coagulation in arteries and veins, which is seldom, because normally the most coagulation happens in the veins. As soon as the arteries in the lung get involved, there is no exchange of oxygen, and you have dyspnea. This means you need air, you have breathing problems. And patients that had corona with intensive care and so on have a long-lasting illness of the lungs, because there is a fibrosis of the lung vessels. So this is very important to avoid it, especially in athletes. The best would be, of course, avoid the infection and to prevent the thrombosis once infected. This reduces the convalescence time. This is demonstrated, and it avoids the thrombus in the lungs, so it improves the performance of the athlete. So in corona, there is one special aspect which has been known only since November last year, and it is that there is one factor which is very highly thrombosis inducent, which is the antiphospholipid antibody. And this triggers especially the arterial thrombosis, which makes us understand why not the veins are affected, but the arteries. So in this phase here, the antibodies are produced. And as soon as you have these antibodies, you start producing thrombosis. So this would be the phase where you have to avoid the thrombosis. Question 1. Should any infected athlete receive anticoagulation? So, as anticoagulation seems to be the way to reduce this problem with the lungs and with the thrombosis, yes, heparin should be given if you know that somebody is infected. We have some evidence to the effect of heparin, not in the early stage, but generally. Now, if you consider that it is an arterial thrombosis and that it is triggered by antiphospholipid syndrome, and in this case we know that aspirin is enough in the other persons having antiphospholipid syndrome aside from corona, we could give aspirin, but this is not evidence-based. This is my recommendation. So if you, for sports reasons, can't give the heparin injection to the patient, you could give him aspirin, and I'm pretty sure that you would help the patient. So as soon as you know that the person is infected, in my humble opinion, we should give aspirin to everybody. Of course, also to the athletes. And this is also already the answer to the second question. The best option, again, would be avoiding a thrombosis. So the start should be just after having the positive test in this moment, just to avoid the D-dimers going up, the thrombosis to provoke, to appear. So this is a personal recommendation without any evidence. But training in lots of kinds of sports is not possible with distance or face masks, so you will be infected. And aspirin with 100 milligrams reduces the signs of illness even if given 7 days before. That is a retrospective analysis just published from the University of Maryland. So perhaps if you just give every athlete training without being infected 1 aspirin a week, you could have a safety base to be sure, even if he gets infected and you make the test once a week, for example, he will be already protected. If you are positive to corona, I would give them every day 100 milligrams of aspirin. And I would check D-dimers on a regular basis, let's say 3 to 4 days. Every 3 to 4 days. If D-dimer goes up, I would add heparin. And also I would add heparin once a day in the prophylaxis dose if there are symptoms of corona, just to avoid a progression. When does the infected athlete start games? This is not my topic. But guessing, if there are no symptoms, I would not stop the athlete to have sports, because sports prevent infection and sports have the immune system up. And so if the athlete feels well, I would give him the aspirin and allow him to make sports. But as soon as there are symptoms, I would allow the body with no high dosage sports, just little sport, and allow a recovery. So I very much hope that this enlightens a little bit your questions, and would be very happy to receive questions and answers. Thank you.
Dear Ayman.
Thank you, Erika. It was a very nice talk, as usual.
I would like to add something, because we had a discussion. Do you hear me? Yes.
Yes.
We had a discussion on the D-dimers earlier. And we discussed on taking D-dimer as a marker at the end of the thrombosis. But I think it is evident at the starting of the thrombosis that the D-dimer levels are correlating with the thrombus activity. So I wouldn't change my presentation after knowing that at the end of the infection and at the end of the thrombosis, the D-dimers seem not to play such a big role.
Yeah, great. Now, please listen to the Arabic translation of your presentation.
Of course. Thank you.
السادة الزملاء الأعزاء، إنه لشرف لي مشاركتكم اليوم والتحدث عن استخدام مسيلات الدم للرياضيين. وكما ترون أن لي عدة اهتمامات لدراسة التجلط في حالات الكورونا مع الكثير من المراكز الطبية العالمية وعلماء الأوردة، ومنهم الزميل العزيز دكتور أيمن فخري. ويتناول الحديث اليوم الإجابة عن 4 أسئلة. 1. هل أي رياضي أصيب بمرض الكوفيد-19 يجب أن يعالج بمسيلات الدم؟ 2. متى نبدأ العلاج ومتى نوقفه؟ 3. متى يمكن أن يعود الرياضي للممارسة الفعلية للرياضة؟ للإجابة يجب أن تعرف أن مرض الكورونا يزيد من فرص التجلط بالأوردة والشرايين، وقد ظهرت هذه الحقيقة منذ اللحظات الأولى في بداية الحالات في مدينة ووهان بالصين، وقد ساهم الهيبارين في إنقاذ العديد من الحالات الحرجة. وإنه من المعروف أن دورة المرض تمر ب3 مراحل: مرحلة العدوى، مرحلة التأثير على الجهاز المناعي للمريض، والمرحلة الأخيرة وهي ظهور أعراض شديدة للمرض. ويجب طبعا الاهتمام بالأساليب الاحترازية لمنع المرحلة الأولى وهي الإصابة بالمرض. أو المرحلتين الثانية والثالثة فهي مراحل العلاج والتي قد تتطلب الحجز بالمستشفى. ويعد الفترة من اليوم السابع للعاشر هي المرحلة الأخطر للإصابة بالمرض، حيث يبدأ الجهاز المناعي في إفراز السيتوكاينيز والأجسام المضادة والمسببة لاستنفار الجهاز المناعي، ويزداد معدل الدي دايمر في هذه الفترة. والآن يمكن أن نلخص تأثير فيروس كورونا كالآتي: الفيروس يساعد على إحداث التجلط بالشرايين والأوردة، وبمجرد حدوث الجلطة بالشرايين الرئوية يصعب عملية تبادل الغازات في الرئة وتزداد فرص التليف في الرئتين. وعلى هذا يعد العلاج الأمثل هو: 1. منع العدوى. 2. منع التجلط إذا حدثت العدوى. ونرجع للسؤال الأول: هل كل المرضى المصابين بكورونا في حاجة للعلاج بمسيلات الدم؟ الإجابة هي نعم، فالأسبرين وحده ليس بالعلاج الكافي. والسؤال الثاني: متى يبدأ العلاج؟ والإجابة هي بناء على رأيي المتواضع يجب العلاج فوراً بعد إيجابية التحاليل دون الانتظار لارتفاع الدي دايمر. وكل هذه الآراء شخصية، ويمكن إعطاء الأسبرين مرة واحدة أسبوعياً وقد تكون كافية عند سلبية النتائج. ولكن إذا استمرت النتيجة إيجابية يجب إعطاء الفريق كله قرص أسبرين 100 ملغ يومياً، والتأكد من التحاليل كل 3-4 أيام. ولكن إذا زاد الدي دايمر وظهرت الأعراض، هنا يجب الاستمرار في العلاج بأدوية السيولة بالجرعة الوقائية. ونأتي للسؤال الأخير: متى يبدأ الرياضي ممارسة الرياضة التنافسية؟ وفي الحقيقة لا أستطيع الإجابة على هذا السؤال باستخدام معلومات موثقة، ولكن عن طريق الاجتهادات، مثل يجب على الرياضي الراحة والعودة لممارسة نشاطه بعد استقرار التنفس بالتدريج، مع استمرار إعطائه جرعة يومية من الأسبرين والمتابعة بالتحاليل. ويسعدني الآن تلقي أسئلتكم مع تحياتي وجزيل شكري.
Thank you, Erika. Now we are going to discussion. I think Professor Ayman
thank you, Professor Mendoza, for the for the very brave lecture. In fact, let me call it like this. I'm with you that COVID is very strange in approach and in pathogenesis. However, if we talk about giving anticoagulants for every infected person, I think this is against what have been accumulated from data in general population. And now the recommendation, even we don't give prophylaxis for mild and even moderate cases. And prophylaxis is giving to severe cases with risk factors and for people in the intensive care unit, putting in consideration the risk of bleeding. So I think we have accumulated data enough to say that we don't need to give anticoagulants for the mild and asymptomatic infected persons. My second point is aspirin. I think aspirin is not going to work in the venous side. So giving an anticoagulant if I have an indication is much important than the aspirin. And sometimes we can give both together. I am with you that D-dimer, which used to be a good negative test, is not of big deal when it is positive, especially with among the inflammation and the cytokine storm that happens. Putting in consideration that we consider that COVID-19 is not a cytokine storm disease as huge as other diseases, for example, the influenza even, or the bacterial infections. So these are my considerations. Do you think anticoagulation for every athlete? Actually, we have our own data for this among athletes and general population. We have thousands of people we didn't give anticoagulants, are doing well. We follow them up for up to 6 months now, and we didn't regret to do this. So it's a point of debate. And don't you think that we need to have more data to say this?
Yes, of course, you are completely right. I am fighting to have data on the persons before getting hospitalized, because we have lots of data from people already in hospital, but we don't have data from the people between getting infected and getting hospitalized. And I'm not talking about anticoagulation for 6 months. I'm talking about aspirin, which you are giving. I mean, there are 2 points. First, we have venous thrombosis in COVID, but the most of the thrombosis occur in the arterial part, and the most dangerous thrombosis, because all the strokes and the pulmonary disease in corona is an arterial thrombosis of the lungs. And this is the thing that causes the people not being able to put oxygen into the blood. And at the end, the most often dying reason is the arterial thrombosis of the lungs. So you have a high proportion of patients having an arterial thrombosis. And if you consider people having a risk of cardiac infarction, of myocardial infarction outside of corona, they take their aspirin daily for years and ages, and nothing happens, and everybody is like okay with it. So to claim, I mean, I'm really trying to make a study, and I tried to do it with Ayman Fakhri in Egypt, and the ethics committee in Germany is horrible, because they want me to have a phase 3 study to demonstrate that aspirin is not harming the people. I mean, it would be so easy to randomize placebo versus aspirin and check people after infection. People above 50, for example, they are at a higher risk. But I'm not claiming to anticoagulate for months, but I claim to say, if you give aspirin, considering it is an arterial thrombosis disease, of course the vein will not be treated, but as to my knowledge, the proportion of arterial thrombosis is much higher than the venous thrombosis in COVID, and you are preventing it before they appear, and possible you are preventing a deterioration of the endothelium and so on. So of course it is not evidence-based, but we don't have any evidence for this phase of the disease.
Yes, you have a point, Erika. Let me ask you, Professor Ramashoti mentioned in a stroke trial the usage of colchicine. What do you think of colchicine in such COVID patients?
You know, I think I found it very interesting. Colchicine is hydroxychloroquine? No, it's different.
Yeah, different.
Okay, and so I'm not so instructed. I thought it was very interesting when I discovered this antiphospholipid syndrome. Hydroxychloroquine is thrombosis preventing in lupus patients. So perhaps this is the way why hydroxychloroquine acts in the first phase, but it is much too dangerous. And with colchicine, I have no experience. I'm sorry.
Let me with the question to Professor Antoniani. Do you have an answer for colchicine?
No, the answer was about the aspirin and the heparin to Erika.
Okay.
Because the COVID cause a very important endothelium damage. Yes. Do you think that the association with the aspirin and the heparin is better for patients in general to avoid the manifestation of symptoms, of course.
You mean giving both together?
Both together.
I don't know. I mean, if you stick to the arterial thrombosis like a myocardial infarction or brain stroke,
yeah.
Usually aspirin is enough. And if you see this Maryland study, which is retrospective, but they had 60,000 patients. I mean, it is a large number. And the fact that having taken one aspirin 7 days ago would significantly improve the development on intensive care unit shows that aspirin plays a role in the pathogenesis of this thrombosis that at the end kills the patient. So it's empiric. I know that. I can't demonstrate it, but it's so easy. I mean, aspirin is not this high level thing. I would give aspirin to the population about 50 for the next half of the year and avoid, hopefully avoid clinical, but I would love to demonstrate it, of course. But I wouldn't give everybody both. I wouldn't give everybody both. I would only give heparin in the very moment when you have this phase, when you are still at home, but you have severe symptoms, like not only a little bit of headache, but severe symptoms at home. Then I would start giving heparin. Perhaps I would start doing it D-dimer triggered. But this is so difficult in Germany, at least, to have them all have them controlled so neatly.
Okay, so the problem is before the symptoms. To avoid the symptoms, you can give the aspirin to avoid the cardiac and the brain system, but not avoid the manifestation in pulmonary system.
But I think you would avoid it because the manifestation in the pulmonary system are thrombosis, arterial thrombosis triggered.
Yes, it's a mere arterial thrombosis. So you think that the aspirin is useful also for the pulmonary localization? Okay, it's very interesting.
It's my idea. Okay. Yes.
No, it's good. Why not? It's good.
Yes, you have a point. You have a point, Erika. It may be working like that. Let me go to Sergio. What do you think, Sergio, of using aspirin and colchicine?
So I have no experience over here in the use of colchicine. My recommendation, considering the audience, would be to stay into trial, not to experiment with that, because there could be, of course, complications. So all brilliant ideas, but the key message for me would be design a trial, go through ethics committee, because we have seen already too many attempts of empirical practice during these COVID months.
And aspirin? What do you think about
that? Again, there is absolutely a rationale, but we definitely need, again, to have it inside a proper trial so that we are sure we can reproduce the data eventually.
Yes, you are right. Thank you, Sergio. Thank you, Erika. Professor Ihab, you have a comment for Erika? I think
he's muted.
Yes.
Dr. Ayman, actually, I have a comment on colchicine and hydroxychloroquine.
Great.
One of the important notions that in patients with lupus and some inflammatory condition, when we use the hydroxychloroquine and even some anti-inflammatory drugs like colchicine, they decrease inflammation, the endothelial inflammation, and they can add to outcome, to a better outcome. And even in pulmonary hypertension, for example, which is a chronic disease associated with systemic lupus, when we give anti-inflammatory, the pulmonary artery pressure decreases due to decreased inflammation and decreased thrombosis. So I think this is a place. It is an anti-inflammatory effect, which is a part of the pathogenesis of the disease. So colchicine also is used in desperate patients who end with fibrosis. So we are trying now to have colchicine to use steroids for long period and also low-dose azathioprine, Iran, and also the antifibrotics, nintedanib and the other antifibrotic drugs. So these are mainly for the fibrosis of the lung or as anti-inflammatory. But the effect is fighting the thrombosis. There are many trials now, and I think at the end we need to have anticoagulants with or without antiplatelets, as Dr. Mendoza has illustrated.
Great. Now, Professor Said Al-Mallah, do you have a comment?
Yes, Professor Ayman. I add my voice to Professor Ayman Farghali. The colchicine, we use it too much in vasculitis, and it can modulate the immunity. So in many autoimmune disease, we can use colchicine, and it is a strong anti-inflammatory drug, and it can be used to prevent the intimal hyperplasia also, and there is a study for that before. So when we use colchicine added to aspirin, it can give a good results, but it is not an anticoagulant, and no anticoagulant effect for colchicine. It mostly used in acute gout and gives a very good result, and in all types or most of the types of vasculitis. So I think it is a good drug. Maybe it is not present in Europe, but still in Egypt, it is a very good drug. Thank you.
Thank you, Professor Said. This is a good remark. Thank you, Erica.
Thank you.
We are happy and we are glad you have with us today. Thank you, Sergio. Thank you, Professor Antoniani. We all thanking you very much to have time with us. By the end of our talk today, I have to wrap up the conclusion. I will make it in Arabic, then in English. من خلال هذه الندوة نصل إلى يجب تصنيف مرضى المصابين بالكورونا من الرياضيين إلى عدة مجموعات أو 3 مجموعات تحديدا. المجموعة الأولى هم هؤلاء المرضى الذين لا تظهر عليهم الأعراض ولكن تظهر إيجابية الفحوصات، وفي مثل هؤلاء المرضى يمكن الاكتفاء بالمتابعة وإعطاء الأدوية الخاصة بالمرض نفسه والمتابعة بعد إعطاء مسيلات الدم. المرضى الذين تظهر عليهم الأعراض مع إيجابية الفحوصات والأعراض البسيطة يمكن إعطاء هؤلاء المرضى جرعات وقائية من مضادات الالتهاب. أما المرضى الذين تظهر عليهم الأعراض وارتفاع نسبة الديدايمر، هؤلاء الذين يجب أن يتلقوا أدوية السيولة ومتابعتهم. أما بالنسبة للنشاط الفعلي، يجب أن يحصل المريض على الراحة لمدة 7 أيام من اختفاء الأعراض و10 أيام من بدء الإصابة، ويعود للتدريب التدريجي خلال 2 أسبوع من الإصابة. هناك عدة محاور للرياضة التنافسية وكيفية إعادة الرياضي للرياضة التنافسية. يجب أن يكون هذا بحرص ومنتهى الحرص لهؤلاء المرضى الذين ظهرت عليهم الأعراض. أما المرضى الذين لم تظهر عليهم الأعراض فيمكن لهم العودة التدريجية لممارسة الرياضة. That's the resume of our conclusion today, I would like to thank the International Union of Angiology and the Egyptian Vascular Society of Egypt to put this workshop under their auspice. I would like to thank His Excellency Minister of Youth for and the President of the University, Dr. Abdelaziz Konsowa, for putting this under their patronage. I'd like to thank Professor Abdelaziz Professor Mohammed Bilal, the Dean of the Sports University in Alexandria, for arranging this great workshop. I'm very grateful to Professor Asad Kiki, our chairman today, for this session and the great workshop. Again, I would like to thank Professor Abdel Basit Hassan, Professor of Sports in the Faculty of Sports, Alexandria, Egypt, for sharing his great ideas with us today. I'm really appreciating Professor Erika Mendoza, Eduardo Ramaciotti, Pier Luigi Antoniani, and my dear friend Sergio Genesi for joining us today. I would like to thank Professor Adel Fathi, my dear colleague and friend Ayman Farghali, Professor Ayman Farghali, Professor Ihab Nabil, my dear colleague and friend too. I also indebted to my great Professor Said Al-Mallah to give his ideas and getting a lot of to spend with us today. Before I go, I would like to thank Professor Ahmed Omran. He is the unknown soldier for arranging such activity. I wish to give him great and many thanks to putting this workshop for reality. Before I go, I would like to thank Mina Farm for sponsoring this workshop and Engineer Walid with his company for data show and help for developing this workshop. Thank you all, and we hope to see and meet again next month in our project of Egyptian Venous Forum activity. Please stay in track, and thank you, and please be safe. Bye-bye.
Ciao, congratulations. Bye.
Thank you, thank you.
Thank you, thank you.
Thank you all.
Thank you.
Thank
Have
you.
a nice day.
Thank you.
Thank you, Professor Fakri.
Thank you, Adel.
Thank you, Professor Fakri.
Congratulations, Ayman. Very good webinar.
Thank you.
Congratulations.
Thank you. It's an honor.
Continue with these webinars, this organization.
Thank you. Under your support, we'll do much, much better.
It's a pleasure for me.
Thank you.
Okay. Bye.
Bye-bye.